Okay, welcome everybody. As you know, I'm Deborah Satz, and I'm going to read yet again the kind of motivation and framing of the class, simply because people come in and out of this class, drop in for particular sessions, so I want to make sure everybody is informed about what we're trying to accomplish. And then also, as you know, this is posted on the Stanford YouTube page, and lots of people watch who've never come to the class and never participated. So I'm Deborah Satz, and along with Paul Brest, I'm teaching this class for the third time. And this is a course that explores disagreement. And as I've said, disagreement pervades our democracy, right now probably at more heightened levels than has been typical, but in general, there's lots of disagreement about policy, whether it's immigration, taxation, reparations, the Mideast crisis, selective higher education, and even the value of free speech and disagreement. Such disagreement is not a cause for concern by itself. We should expect in a democratic society, one not ruled by a king or an autocrat, that people will disagree about many things. Some of the deepest questions we have about morality, religion, and value are hard to think through. Even people who are well-motivated and conscientious answer these questions in different ways, maybe because of their life experiences, which differ, or because the facts are hard to pin down and admit of various interpretations, or because they are willing to make different trade-offs among competing values. As I've said many times, disagreement is a feature of democratic societies and not a bug. But not all disagreement is productive or reasonable. Sometimes people fail to consider inconvenient facts and close their minds to evidence and reasoning that doesn't support their favored view. Facts can rule out certain views or make holding them very costly. In addition, and quite recently to a pretty upsetting degree, a culture of incivility prevails with respect to those with we disagree. And by incivility, I'm not talking about politeness. I'm talking about the failure to treat other people with respect simply because they hold different views on matters we care about and care about a lot. It's pretty easy to be kind of respectful or indifferent to people when you disagree with them and it's something you don't care about. But it's when the stakes are high, when you really care about an issue and it's important to you, and living together with people who see things in a different way, that's a challenge. But it's a challenge we're up to, we have to be up to as a society, and we have to be up to as a university, because the mission of the university, which is the pursuit of knowledge, absolutely depends on the free exchange of ideas and openness to question received positions. History shows us how often we get things wrong, how vulnerable we are to narrow-minded provincialism, even when we're trying our best to figure out the truth. And I've quoted from John Stuart Mill and On Liberty, who mentions the cases of Socrates and Jesus, the first executed for impiety and immorality, the second for blasphemy. The human race is, to put it bluntly, capable of monumental error. So each class, we're focused on different topics, and we have speakers presenting for about 15 minutes, give or take. And then these speakers join us for a conversation on stage. They all have different perspectives and expertise, and we explore the issues with them. And as you know, today's issue is a very controversial one on gender-affirming care for minors. And with that, I'm going to turn it over to Paul, who's going to introduce the speakers, and then we'll begin. So thank you for being here.
So before introducing our two guests individually, I should say that they are both refugees from Boston, one of whom only made it out on probably the last flight out of Logan Airport last night. Anyway, Amy Tishelman is a clinical and research psychologist and a research associate professor at Boston College's Department of Psychology and Neuroscience. She was employed at Boston Children's Hospital for almost 3 decades, where she worked extensively on child maltreatment, interpersonal violence, and trauma. Among her roles at Boston Children's Hospital were directing child protection clinical services and programs that provided clinical care to youth and young adults with intersex variations and gender diversities. Dr. Tishelman is an expert in gender diversity and sex trait variations in these populations. She's been awarded grants by the National Institutes of Health to study them. She's an international lead in writing the child chapter for the World Professional Association for Transgender Health, and is co-chairing a national task force on variations of sex traits and intersex variations for the American Psychological Association. Alex Byrne is Laurance S. Rockefeller Professor of Philosophy at the Massachusetts Institute of Technology. By pure coincidence, one of last week's guests, Stephen Macedo, was also a Laurance Rockefeller Professor at Princeton. Professor Byrne's main interests are philosophy of mind, epistemology, metaphysics, and the philosophy of sex and gender. In 2023, he authored a book, Trouble with Gender, Sex Facts, Gender Fictions, which discussed transgender identity. And in a 2024 New York Times op-ed with his wife, the evolutionary biologist Carolyn Hoven, they criticized the increasingly common phrase, sex assigned at birth, arguing that sex is a fundamental biological feature with significant consequences for our species, so that there are costs to misconceptions about it. Professor Byrne was one of 9 co-authors of a comprehensive review of treatment for gender dysphoria in minors, published by the Department of Health and Human Services. In a subsequent article in the Washington Post, he wrote, after surveying all the evidence and applying widely accepted principles of medical ethics, we found that medical transition for minors is not empirically or ethically justified. And now, before Dr. Byrne comes up first, let's put up today's polling question. Should puberty blockers and hormones be a medical option for gender-distressed minors? Yes, about 58%, no, about 42%. And with that, Professor Byrne takes the podium.
Well, thanks very much for inviting me and for putting on this event, and it's an honor to be partnered up with Amy Tishelman. So we're now in the age of the transgender child, the jazz age, as we might call it, after Jazz Jennings, whose transition from boy to girl was chronicled on the reality show I Am Jazz. The jazz age began in 2007 when Jazz was interviewed by Barbara Walters on 2020, before many of you were even born.
Alex, can you put the mic?
Yeah, sure. So to the younger members of the audience especially, it might be hard to see what all the fuss is about. Okay, so our topic is gender-affirming care, and specifically gender-affirming care for minors. That care is supposed to treat a condition, a medical condition called gender dysphoria, or in older terminology, gender identity disorder, roughly extreme distress at one's sexed body and associated social expectations. Now, the reason why I'm here is, as Paul mentioned, that I was one of the authors of the Health and Human Services Review Treatment for Pediatric Gender Dysphoria, Review of Evidence and Best Practices, which was published in May of last year. The final version of the review was published in November following peer reviews, which are all available on the HHS website. Now, as Paul also pointed out, in effect, I'm only a fake doctor, but fortunately there were some real doctors on the 9-person team of authors, and I will do my best to channel the expertise of my colleagues, but you should discount my remarks accordingly and, of course, fact-check everything I say. So what is gender-affirming care? Here's Diane Ehrensaft from UCSF, a leading authority on the practice. The gender-affirmative model provides support for children to evolve into their authentic gender selves, no matter at what age. Treatment includes gender-affirming medical interventions, puberty blockers, cross-sex hormones, and surgeries. And the really controversial components are these gender-affirming medical interventions. Here are the latest recommendations from the World Professional Association for Transgender Health, or WPATH. This is from their Standards of Care 8, on which Amy was an author. Puberty blockers can be given at Tanner stage 2, the start of puberty, which can be as early as 8 in girls and 9 in boys. Cross-sex hormones are typically given at 16, but could be given at 14. Surgery has no recommended age limits apart from phalloplasty. Mastectomy is by far the most common surgery for minors, as you can see here, sometimes going as low as 13. These are extraordinarily drastic treatments for a psychological condition. Typically, the child and adolescent patients are physically healthy. If blockers are given at Tanner stage 2, followed by a prolonged period of cross-sex hormones, then sterility is guaranteed for males and close to guaranteed, at least rendered extremely difficult for females. Still, the US medical establishment is firmly behind these treatments. In 2022, the then Assistant Secretary for Health, Rachel Levine, said the following: gender-affirming care is suicide prevention care. It saves lives. It is founded on a vast body of medical literature. WPATH assesses the full state of the science and provides substantive, rigorously analyzed, peer-reviewed recommendations. Side note on WPATH, it turned out later that they'd suppressed the publication of evidence reviews that they'd commissioned from Johns Hopkins because they didn't like the results. But back to the medical establishment. This is the American Academy of Pediatrics, just after the recent Supreme Court decision upholding Tennessee's ban on gender-affirming care. Gender-affirming care remains evidence-based, medically necessary care that improves the health and well-being of transgender youth. So the controversy over gender-affirming care has been taking place against dramatic shifts in transgender identification and the patient population presenting to gender clinics. So this chart illustrates transgender identification by sex and generation, 2021. 22, you can see that prevalence is much higher for Gen Z, early teens to late 20s, with females, the ones in green, being twice as likely to ID as trans compared to males. And this chart illustrates referrals to the UK's now defunct Gender Identity Development Service, or GIDS, from 2010 to 2022. As WPATH Standards of Care puts it, there has been an exponential growth in adolescent referral rates, mostly due to adolescent females in green on the chart. And here are GIDS referred patients by age and sex, 2018 to 2022. This time the females are in orange for some inexplicable reason. And you can see that it's mostly girls aged 15 to 16. How did the blockers, hormones, surgery pathway for minors begin? Well, in 1998, two Dutch researchers, the psychologists Peggy Cohen-Katniss and Stephanie van Goosen, reported on the first patient, a dysphoric female given puberty blockers around 1987 when she was 13. That treatment with puberty blockers lasted for 5 years, and then testosterone and multiple surgeries followed. It seemed to be a big success. Describing the patient, they write, she'd always been a classical tomboy in her play activities and toy and peer preference. And she wished to be a boy early on. An interesting remark about family dynamics, she had many conflicts with her father. His Mediterranean background made acceptance of his daughter's masculinity very difficult. No prizes for guessing the patient's sexual orientation. So the next landmark was the publication of these two papers in 2011 and 2014 by Annelou de Vries and colleagues, reporting on an initial cohort of 70 patients from a clinic in Amsterdam. The cohort of 70 had been reduced to 55 by the time of the second paper in 2014, with 3 adolescents diagnosed with obesity and diabetes, and 1 dying from surgery as an indirect consequence of puberty suppression. Anyway, these papers led to the formulation of the so-called Dutch protocol for the treatment of pediatric gender dysphoria, which is the blocker's hormone surgery pathway, but with much, much stricter gatekeeping than the affirmative model. Now, significant childhood gender nonconformity, for example, in toy preference, is a requirement for a diagnosis of gender dysphoria in childhood, and childhood gender nonconformity is strongly associated with later same-sex attraction. The Dutch researchers measured sexual attraction in the cohort of 70, and this is what they found. Same-sex in light green, same-sex attraction in light green. Exactly 1 of the original cohort of 70 was a self-declared heterosexual. Bear in mind that the base rate of homosexuality is 2 to 4%. Now, to stay on this theme for a little bit, the first dysphoric patient, who I mentioned a few slides back, to be put on puberty blockers, was interviewed for the New York Times podcast, The Protocol, which is about the Dutch protocol and how it influenced gender medicine in the US. The podcast came out last year. It's well worth listening to. And here's the trans man, called FG, in the podcast recounting his childhood. When I was 12, I met a girl. She was in my class. She was also a bit of a tomboy. We became very close very quickly. I always did gym with the boys, but so did she. And at the time, we both decided that we were boys. And I was convinced that she was the same. And she just turned out to be quite a butch lesbian. Well, that was one alternate life history for FG, and we can only speculate how that might have turned out. This is from the British journalist Hannah Barnes' great book, Time to Think, about the collapse of GIDS in the UK. One clinician recalls families who remarked, "Thank God my child is trans and not gay or lesbian." There was even a dark joke in the GIDS team that there would be no gay people left at the rate GIDS was going. Now, the Dutch protocol led, as I said, to the gender-affirming model in the US at the very start of the Jazz Age, in fact, 2007. And it began at Boston Children's, where Amy worked. And this paper is about, by Laura Edwards-Leeper and Norman Spack, is about the protocol at Boston Children's. Now, gender medicine, if you've read any of this literature, is an unusual medical field, partly because clinicians often take suspect or obscure theoretical claims for granted. We've already seen Diane Aronsarf talk about the authentic gender self. So here's another example in this paper. The authors refer to the increasingly common belief, which they plainly endorse, that a transgender individual's gender does not change, as his or her brain or soul has always been his or her affirmed gender. And something about childhood gender nonconformity, as I said, is required for a diagnosis of gender dysphoria in childhood, childhood gender nonconformity greatly increases the odds of later same-sex attraction. This is something that I've always found a little mind-boggling. In the seventh version of W-Path Standards of Care, the one before the previous one, which came out in 2012, gender nonconformity is actually in the title. It's like part of the description of the patient population. I mean, perhaps transsexual people have special healthcare needs, doesn't seem so implausible. But do gender non-conforming people? I mean, imagine if the title had said, Standards of Care for the Health of Transsexual, Transgender, and Sissy Boys and Tomboys. Why does putting gender non-conforming in the title make it any better? And in the latest Standards of Care, it's gender diverse rather than gender non-conforming, but that's basically the euphemistic way of saying the same thing. Okay, so one more very important piece of background. If gender dysphoric children are not socially transitioned, their dysphoria will typically resolve with time. Here's a study of 139 dysphoric boys, first assessed at an average age of 7. When they were followed up at an average age of 21, 88% were no longer dysphoric. Of the 17 who were still dysphoric, only 8 were being medically treated. Now, I just showed you some results from a study, and your initial reaction should be not, wow, that's an interesting fact, but cautious skepticism. After all, I picked the study. Perhaps this one is an outlier, and other studies come to a different conclusion. Or perhaps the study has methodological problems, significant loss to follow-up, for example. Now, as it happens, it is a well-conducted study, consistent with the others. But the point is that cherry-picking studies can lead to very misleading conclusions. All relevant studies need to be taken into consideration, graded for quality, and the evidence synthesized in a transparent and reproducible manner. That is the task of the so-called systematic review, which is at the top of the evidence-based medicine pyramid. At the very bottom is expert opinion, which includes consensus statements. Notice the information volume increases, unfortunately, that is always the way, with decreasing quality. In other words, that's why it's a pyramid shape, bigger at the base than at the top. So to cut a long story short, the message from the many systematic reviews of gender-affirming care is that the evidence of benefit is very weak. It's like so weak that we just don't know whether this care helps or hinders. If you add to that the known and plausible harms of these treatments, it follows that the risks carry the day. No responsible, this has got nothing in particular to do with gender-affirming care or anything like that. No responsible doctor should offer a treatment with known serious harms, but with no known compensating benefits. Gender-affirming care for minors is such a treatment. Okay, Amy, you're up. So you can use this, but somewhat confusingly, that is the advance button, or you can just use that.
Okay, thank you. Hi, everybody. So happy to be here today, and I really appreciate the possibility of engaging in dialogue with people who don't really agree. But in fact, as I talked to Alex, we have many areas of agreement, and a lot of times when you think that you're opposed to somebody and you come and talk together, you do have areas of agreement and disagreement. So in some ways our views merge, and in some ways they diverge. And I really respect his point of view and get a lot out of hearing what he has to say. But yet we do have different perspectives, and this is just a depiction of how people can have the same evidence and see the same information, but interpret it differently because often we come from different vantage points. And part of our different vantage points are the fact that I'm a clinician. I've been down in the trenches working with youth and with parents and doing the research which is very hard to do. And Alex is a philosopher and has a good background in ethics and has a lot to add in this area. And so I appreciate having different perspectives and trying to join together to figure out what's going on in this field. So just as a stipulation, or just to let you know how I think about this, I believe, and you may not, that there are transgender people in the world. It's not a 21st century phenomenon, and it's not a phenomenon that's localized to the United States. Globally, people recognize that there are transgender people, and there have been transgender people for a very long time. And this is just a random article that a friend sent to me because her father in the 1970s was a psychologist in Nebraska who treated transgender adults. And this was an article that was published in Omaha in the 1970s about their treatment with transgender people that specifies that at least 1,000 people in the United States had already had transgender-affirming surgeries by the 1970s. So it's not a new phenomenon. What's new is the number of people coming forward identifying as transgender, youth being treated, and the media and government basically getting involved in examining this issue more closely. And I would say that we're talking about research, which I'm a researcher, obviously is very important, but that's not the only way to know about something. And honestly, if you look at pediatrics or medical care in general, when treatments are initiated, you're not going to have the highest level of empirical basis for treatments. If we insisted that all interventions for youth could only be provided if we had the best level of evidence, we would never initiate new treatments. You initiate new treatments because of your perceived needs, and then you study them. And the reason you initiate treatment often is because people present with a need, whether it's a rare form of cancer or a need for gender-affirming care. People present with needs, and then you figure out what to do, and then you really should study to make sure you're doing the right thing and refine care or not give care anymore. And so there's research, we know things, and psychoanalysis and many interventions were based on case studies and clinical care. That's how gender-affirming care started with Norm Spack and others, was being presented with kids who wanted to have treatment and perceiving a clinical need. So there's clinical care, there's a historical context, which I'm talking about, then there's also testimony from transgender adults, and transgender adults often advocate for interventions for children and talk about how miserable their childhood was, how traumatizing it was, and how much they don't want children to have to endure what they endured when they were kids. So part of the inspiration for treatment comes from adults who say they've always been transgender, they knew when they were young. You can read books of people who talk about that, and that they would like to not eradicate what has been provided for kids for ensuing generations. So I think that that's important. I don't have time to play videos for you. I'm told I only have 15 minutes, and I'll probably go over, and I've cut out a lot of slides. And as a tangent, I can't cover everything important. I could talk up here for 3 to 4 hours, and I only have 15 minutes. So you can ask me questions after, and I can talk about things I didn't have time to talk about now. But if you're interested, Norm Spack, who started the first gender clinic as an endocrinologist at Boston Children's Hospital and Harvard Medical School in 2007, along with Laura Edwards Leeper, has a TED Talk, and that's a link to it, where he talks about why he wanted to start the gender clinic. And it was based on what I said before, his patients who really, really wanted intervention so that their bodies didn't change during puberty in ways that were really, really they didn't think they could tolerate, and that were incongruent with their gender as they perceived it. And so that treatment started at Boston Children's Hospital, was ongoing in other parts of the world, particularly, as Alex said, in the Netherlands, where a lot of the early research also began. Tragically, or very unfortunately from my point of view, the clinic at Boston started in 2007, and then in the decade or 2 decades since, many hundreds, probably, clinics sprouted in the United States and globally, but didn't prioritize research. And I can only think that had these clinics prioritized research from the beginning, we would know so much more than we do now, because I agree that there's a lot of limitations in research. I was first hired to do research in 2013 as research director for the transgender program 6 years after it started, and I was hired for 4 hours a week with no other resources. So if you are engaged in research, you know that's very limited, and I was hired basically to try to help write a grant with three other services across the country to do outcome research on transgender care. But there wasn't a lot of energy put into that. Not to say that was a bad thing, it was a good thing. But most of the clinics throughout the country really did not put a lot of resources into research, and I think it's easy to say that was a mistake retrospectively, and I don't understand completely why prospectively people didn't realize how important research was going to be. And a lot of research has been criticized as inadequate. Some people push back on that. There's certainly limited data, but there is some data. I am one of the critics of research, even though I've been a participant in research. I think we could and should do better, and I think that it's important. So some of the limitations in research, just to add to what Alex has said, are that there haven't, in my opinion, and it's just opinion, there haven't always been good measures of gender dysphoria. And I think, like, if you really want to understand the research, and a lot of you at Stanford have good backgrounds in research, you should read the research, because you need to look carefully and dig deep to see what kind of assessment measures did they use. Are they really adequately defining what is a transgender kid? Are they using measures of gender expression and nonconformity rather than of gender identity, which actually I think happened? And in my opinion, in some of the research, especially the early research, there was an over-identification of who was transgender, and then it looked like a lot of kids were no longer transgender when they were probably not transgender in the first place. That's just one important limitation. There's a lack of control groups, which is really hard. Without control groups, it's hard to interpret data and observational data. There's very good reasons there haven't been control groups, which are that there are ethical concerns about denying some groups of kids time-sensitive interventions because they need a control group for research. That's now going on in England, where they've instituted some research on puberty blockers with control groups. People claim that's unethical because they're denying intervention for kids who will have to go through what they think is the wrong puberty in order to have a control group. Other people think it's unethical because nobody should have access to puberty blockers. So from both ends of the spectrum, people think it may be unethical to do that research. I can't tell you what to think. But one of the problems with a lot of the research that's occurred is that there's lack of contextual data. So for much of the research on outcomes, they've reported that kids have gone on puberty blockers or cross-sex hormones, and then they report if the kids are still anxious, depressed, suicidal, etc. But they don't report on whether there have been any co-occurring interventions. So without a control group and without knowing if there are co-occurring interventions, we really can't conclude that kids' anxiety and depression is alleviated because of the medical interventions. Maybe they got psychotropic medications, maybe they're also had therapy initiated. So that's a conundrum in trying to understand the research, for instance. And we don't have long-term data. Like when I was at Children's, I was trying to institute a study where we could track down our first patients who are now in their 30s and see whatever happened to them. We don't know. And so even the longitudinal data we have is relatively limited to just a few years. And we don't know how people are doing in the long run and if they're happy with their interventions or not. What we do know is that we don't have a massive number of people coming forward saying they wish they hadn't transitioned. We don't have that. Most people seem to be happy about it. I do have a colleague, Kinnan McKinnon, who's doing research on people who are detransitioning and saying, going off the medications. Only a small fraction of those people say they regret having gone on medication in the first place, and many of them say they're detransitioning because the social ramifications of being transgender are very difficult. Some say that they made a mistake. Some people are actually initiating lawsuits against their providers, saying they should never have been put on puberty blockers or car-sex hormones, and they're really unhappy. That's a very small group of people, but it's growing, and I think it's important to realize that most of these people were saying they didn't have enough of an assessment before they initiated care. And then finally, there is a perception, it may not be true, but there is a perception that some people hold that those of us, or that those people who are engaging in the empirical research in this field are people who already assume that gender-affirming medical care is good for youth, and they're using the research in order to support what they already believe. That would be confirmatory bias, and that's problematic. I think people would say the same thing, however, about the Health and Human Services report that Alex was involved with colleagues. That maybe you could address this later, Alex, but how were people chosen to write that report? Many people think that people were hand-chosen who already thought that were skeptical about gender medical care for youth, and so they picked those people to write a report that would be excessively negative about it, and reviewers who would be who wouldn't be as critical as they could be. I don't know if that either of those criticisms are justified, but they're perceptions that further polarize people, I think. Other concerning, I can't go into all this now because I'm running over, but there are concerns about the changing demographics of people coming in for gender-affirming care that I'd like to talk about later. The exponential rise in number of youth self-reporting that they're transgender and would like care, and changes in provider practices, which are moving towards fast-forwarding medical interventions, which wasn't done when medical care was first provided in the United States, when it was a much slower process. And what I would like to do is step back a little bit, just because I want to respond to one thing that Alex was talking about, which is that the quality of evidence is not very strong. And what I said is that always when you initiate an intervention, quality of evidence is limited. But in pediatric care, it's very common for quality of evidence to be limited for even when there's clinical guidance. And if you look at this is a 2025 article that evaluated the quality of evidence in many practice areas in pediatrics. And you'll see level A, which is the highest quality evidence, was only 11% of pediatric interventions. And if you count level B, which is some observational studies that are well done, as well as level A, that's 58%. But that means 42% of interventions in pediatrics are based on not optimal evidence or limited evidence, but we still engage in that care because no care is often dangerous as well and is an option that needs to be carefully considered. And I would encourage you to go look at these articles because they're important. And I'm going to focus on one area just very briefly that I'm concerned about, much more concerned than I am about gender care, which is psychopharmacological interventions with youth, very parallel to gender-affirming care, medical care. It's been exponentially, the numbers of kids on psychiatric meds are growing exponentially. Psychiatric meds work because they affect brain and brain development. We don't necessarily understand how they affect neurodevelopment and normal neurodevelopmental processes, and we do know that there's significant harms that are sometimes side effects of these medications, like significant obesity, movement disorders, etc. Yet I don't hear people calling for bans of pharmacological interventions with youth, even though so much is unknown. And that's because the correct question isn't is there any harm from this intervention? The correct question is, what is the harm to benefit ratio? And people will initiate psychiatric interventions with medical care because they see the benefits as profound, even though the side effects and negative implications can also be profound, but they see the benefits as even more important. And as with gender-affirming care, there are behavioral interventions often for mental health challenges, but often psychiatric interventions or medical interventions trump that in actual practice. So this is actually from last week. This is from January 2026, where the study found that there's like exponentially increased use of psychotropic medication in youth, drug interaction risks, and very few of the interventions with youth come from studies of youth. They come from testing these medications on adults, like hormones are tested with adults, and then using them as kids with unknown impacts on developing brains and not even empirically validated dosage amounts, et cetera. So I just want you to realize there's a spectrum of concerns in pediatrics. Gender-affirming care is just one of them. I also want to talk about the evolution of care. When I started in this field, this was an article I'm a co-author on from October 2013. We thought about gender-affirming care differently than people think about it now. There's been a creep effect, or I don't know what you call it, that what's called gender-affirming care now is very different from back then. And for instance, this is an excerpt from the article where we say, everybody is not conforming, non-conforming is not transgender. If kids are thinking they may be transgender, they should engage in an exploratory process with a therapist. And we understand that gender can be fluid, and that if a person thinks they're transgender at one moment, they may not always think they're transgender. And so we recommended, therapy and exploratory therapy, which doesn't mean different than conversion therapy. Conversion therapy is when you go to a therapist with a goal. We want you to change. We're going to try to make you not transgender. And that's the goal, is that at the end of therapy, you'll be cisgender, not transgender. Exploratory therapy should be neutral. Like I would tell my patients, I don't really care what gender you are, but I do care that you're happy and that I'm a psychologist, that you go through life in feeling good about yourself and confident. But this is an article with one of the same authors that just was published in 2025 as a response to the Health and Human Services report, saying that exploratory therapy and conversion therapy are the same thing. I think that's really terrible, and I think that means like all therapy is conversion therapy, because most therapy is exploratory. And I think that distinguishing those two concepts is really, really important. So I'm going to try to hurry, but I just want to talk for a minute about what are the justifications for continuing access to gender-related medical care for kids. We have adults saying it would have changed their life for the better if they had access to care, and that it was really hard growing up without access to care. And we have historical, clinical, cross-cultural recognition that transgender people exist. And we may not understand the etiology or why, but we knew that the sun and the moon existed before we understood anything about why. Lots of things we observe in life we know to be true, and we don't understand them. Eliminating any access to gender medical care for youth really prohibits the possibility of actually refining care and making it better, because we can't do more research. It basically means giving up on those people who may be transgender for their whole life and failing to treat them, as opposed to trying to make care better and more careful and doing really strong research. Eliminating all care means we preclude both research and individualized care. It also overrides the tradition in pediatrics, which is for individualized care with providers, guardians or parents, and kids making shared decision-making with understanding all the information that could be understood about a treatment. I do think parents and kids should be made aware of what we do know, what we don't know, what people are worried about with research, what people are in agreement about, et cetera. And I just want to point out, if you read the Health and Human Services report and a lot of the systematic reviews that have been done, they don't say that gender-affirming care is not beneficial. They say that the research isn't strong enough to make a conclusion. So the fact is that limited evidence is not no evidence. The evidence we do have suggests that interventions are beneficial for people. It suggests that detransition occurs, but regret is rare, and there may be more detransition in the future because so many more people are choosing medical options, but we don't know that yet. And limited evidence may obscure, in my opinion, I wrote a paper about this, but I haven't submitted it, but limited evidence may really obscure the positive impacts of intervention, and I'll say this really, really fast. One of the issues that I'm most critical about in research and people who criticize the research is the outcome data. A lot of the outcome data says that we're not seeing kids who receive medical interventions like hormones. We're not seeing that they're no longer depressed or anxious or suicidal. But of course not. Hormones and puberty blockers treat gender incongruence. They're not empirically justified interventions for anxiety or trauma or suicidality. And cisgender people and adolescents especially are showing huge morbidities in terms of anxiety and depression. Those same experiences that are causing depression, cisgender people affect transgender kids as well. And as I said, I didn't say this, but research shows that transgender individuals as kids have more exposure to toxic adversities than kids who are not transgender, like family rejection, child abuse, severe bullying, which across the board bullying globally is a predictor of suicidality. So that's not an argument that medical intervention is not working. It's an argument that sometimes medical intervention is not enough, that maybe it will need to be augmented by psychological interventions as well. And maybe the kids who are doing the best have had psychological interventions. We don't know that. So I think I'm going to stop here because I'm going over too much, but just in terms of recommendations going forward, I think it would be good if we could depoliticize gender care for youth. I think it would be really important for people like me and Alex, people who have different perspectives and different belief systems, to come together and create a prioritization of what should be done in terms of research and how to promote these issues, because there's so much paranoia about people's perspectives, that people like Alex don't care about kids, which I don't believe at all, or that people like me who don't think that gender-affirming care should be abolished are too one-sided. I think people should talk to each other, engage in collaborative research together, and that would dispel some of those concerns and help us refine what we're doing. I think it's important that if gender care for youth does continue, we do really good, solid research, and the resources get put into research. And also think that psychological care should be elevated as central. So that is something that many people across the globe think. Right now, there's been a tradition of starting gender care in medical clinics and having, in the hierarchy of care, medicine really prevailing and even dictating the way mental health care occurs. I think it should be truly interdisciplinary. And when somebody comes in because of gender-related distress, I don't think it should be a knee-jerk, well, the first thing we do is give you medical care. Not even every kid wants it. I've had kids say, I'd rather not. I'm afraid of being on lifetime medical intervention. I just want to figure out how to live like this without medical intervention. So it's really important. I think I should stop there, just say the overarching goal for me is to get it right for every kid, and to support kids in developing in a way that makes them confident, happy, have strong relationships, and feel good about themselves across their lifespan. So thank you.
Great. Well, I want to give you a chance to respond to each other, and then I have a couple questions, and then we'll do the poll again, and then we'll open it up to the audience. So, Alex.
Is this on?
I think it's on.
Okay. Is it on? All right. Great. Amy, thanks so much. So a couple of things on which there's definite disagreement, definite agreement before I get on to the disagreement. Yes, of course we should depoliticize this issue. It is most unfortunate that in the US, the pro-gender affirming side is coded blue and the anti-gender affirming side is coded red. There's no reason intrinsic to this issue why it should be this way, and it certainly isn't that way in the United Kingdom. So in 2020, the Cass review, which is the most exhaustive investigation to date of the evidence for pediatric medicalized gender care, that was commissioned in 2020, along with a bunch of associated systematic reviews. The report took 4 years to write, headed by this very distinguished pediatrician, Hilary Cass. The report came out in April of 2024, and it came to very, very similar conclusions, not exactly the same, but pretty consistent conclusions that were pretty consistent with the conclusions of the HHS review. And that was basically immediately accepted by both political parties in the US. It's in the UK, left and right. So here, at least, I think the UK has something to teach the US. And then the other point of agreement is that the issue of bans and whether the federal government should be threatening hospitals by withholding federal funds because they're offering gender-affirming care, that is really whatever you think of that, that is a totally separate issue from the question of whether this care is efficacious or not. Even if it's not efficacious, even if it's positively harmful, that doesn't mean that the federal government should step in and start throwing its weight around. We can certainly talk about bans, but I just wanted to stress that that's a separate issue. Can I just ask, I don't want to ramble on, but I do have some questions for Amy. So the first question is about your claim that your claim that transgender people have always been with us, and I wondered what you meant by that. It's certainly true that gender nonconformity of various kinds has always been with us and has been institutionalized by societies in various ways. I mean, for instance, a bunch of societies, including North American Native American tribes, have so-called third genders, and one is still going in Samoa. They have a third gender called the Fa'afafine, who are basically feminine gay males who live as women, but they don't think of themselves as women. They don't go around saying that they are women. They're viewed as a separate species. You had the example of Gail, and I strongly suspect that Gail was heterosexual and almost certainly not markedly gender nonconforming as a child. Gail resembles Caitlyn Jenner much more than she resembles Jazz Jennings. These are two presentations of gender dysphoria which are really very different. Their etiology is very different. We're not talking about extremely feminine proto-gay boys when we're talking about Caitlyn Jenner, and neither, I suspect, when we're in the case of Gail. So my question for you on this point is, you said that there were transgender children. So how are you understanding that? If someone said, okay, Amy, what is a transgender child? What would you say?
It's actually really hard to predict a kid's gender as they get older. What we do have are kids who are gender diverse and who are saying when they're young that they're boys or they're girls and that they're in the wrong body. So when I started in this field, it was very different. People were not talking about transgender youth. Families were coming in with little children, and they'd never heard of anybody who was transgender. The kids never heard of anything like transgender, and their kids were screaming at their parents, "I'm not a boy, I'm a girl, I'm a girl." And the parents were like, "I don't know what to make of my child. I've never heard of anything like this." It was really remarkable because these were kids who were definitely alone. They weren't imitating any of their friends. Nobody knew anybody who was like this, and these kids were still persistently saying, "I'm a girl, I'm a boy," and it came out of nowhere. But even in the child chapter, I was the lead of the child chapter. That's not adolescents or kids who get medical care for the World Professional Association of Transgender Health. We didn't call these kids transgender. We called them gender diverse because we don't have a lot of research on the development over time of who's going to have a stable transgender identity and who isn't. And there was an acknowledgement in our chapter. It's an acknowledgement in the Gender Affirmative Model article I showed you from 2013 that there can be gender fluidity, but there are also people who from the time they're very little and until they're adults and throughout their lifespan have been identifying and do identify as transgender without ever not identifying that way. And there are records and books that people have written about what it was like to be a kid and be transgender and not be recognized as such. And I'm just saying there were always transgender people. I'm not a historian and I'm not an expert on this, so I'm speaking a little bit out of my scope, but just based on the fact that there were people saying they were transgender for a long time, requesting sex change, what were called sex change operations, for a long time, and surgeries, and there's accounts of them. I just read a book that was written maybe in the 1990s or 80s in Florence about the transgender community in Florence, a detective novel that somebody gave to me. and you can find accounts of transgender communities that have existed even in the United States 50, 100 years ago. One of the first transgender famous people to come forward was Chris Jorgensen, now Christine Jorgensen in the Bronx in the 1950s, have a sex change operation. Hemingway's son became Hemingway's daughter. So it's not a new phenomenon. What it means is hard to know because it's a subjective experience. There isn't a blood test to confirm that somebody is trans or not. You have to take their word for it, which is not unusual in psychiatry or psychology. Often there isn't a concrete criteria like a blood test you can give to understand what somebody's internal experience is.
Yeah, right. Although, as you essentially pointed out when you mentioned Christine Jorgensen, the phenomenon of medically transitioning from one sex to the other, that is there are a few examples in the early 20th century, but that is essentially a mid and later 20th century phenomenon. So is a transgender child a child with persistent cross-sex identification that continues throughout the child's life?
Well, as I said, even in the WPATH standards of care, we didn't call children transgender. That was that was a consensus also among the authors of that chapter, because we understood that kids were gender diverse, but we didn't know who would really have a lifetime identification as transgender, and actually how people would start to identify in adolescence. So, I don't personally tend to use the word transgender for children. I use gender diversity, but some of those gender diverse children will be gender diverse and self-identify as transgender as they get older. So I don't want to say we can predict 100%. We can't. I think with more research, I was actually part of a research group that got an NIH grant to study gender development in gender diverse kids, to try to understand how to predict. That was I left that study when I left Children's Hospital, but I also think it was disrupted. More recently, NIH withdrew funding, as I understand it.
Okay, but then I'm going to take over.
Okay. Okay. One more. Awesome. So I think there might be some genuine disagreement about the strength of the evidence. So the HHS review has this very substantial Appendix 4, which is an umbrella review of systematic reviews. Essentially, it's a systematic review of systematic reviews. And the conclusion of that appendix is that, to put it in evidence-based medicine speak, the relevant, the quality of the evidence is very low, or as they put it, the evidence is very low certainty for whatever outcome you want to name, whether it's the relief of anxiety, the relief of depression, the relief of gender dysphoria, improvements in quality of life, whatever. For any of these outcomes, the quality of the evidence is very low. It's uncertain. And what that, and I should also add that some of the systematic reviews which we used to compile the appendix were co-authored by Gordon Guyatt, who's the father of evidence-based medicine at McMaster University. And in fact, when it comes to the issue of whether this care should be provided, he's on Amy's side and not on my side. But as far as I know, Guyatt does not disagree with our assessment of the evidence in that appendix. Okay, so what does very low certainty evidence mean? Well, what it means is that we are uncertain whether this treatment will, let's take depression as an outcome, whether it will make depression better, in other words, it'll reduce depression, or alternatively, maybe it will have no effect on depression, or maybe it will actually increase depression, right? Those three options. The evidence doesn't decide between them. So I think the way Amy was presenting it is that, we have some limited evidence that there's going to be a positive outcome. The evidence is sort of trending towards the positive, but it's just not conclusive. Okay, that is definitely not the conclusion of the HHS review.
May I make a comment? I think I mentioned, but I just want to go back. I understand why you're concerned that depression doesn't go away or anxiety doesn't go away. I think that's a really important point that I strongly disagree with. I was one of the people writing one of the first outcome grants in 2014, and I said at the time we were writing the grant that we can't expect that people are not going to have depression, anxiety, suicidality after receiving gender-affirming hormones because they're people. We should be expecting them to have probably greater levels of anxiety, depression, suicidality than cisgender kids who don't have the same exposure to adversities that transgender youth do. And the gender-affirming hormones are not meant to dispel all depression, all anxiety, and all trauma. You need interventions that are actually created and empirically examined that reduce depression, anxiety, and suicidality. Hormones are meant to reduce gender incongruence. That means the feeling that your body doesn't match your gender and who you are. And I told my colleagues when we were writing the grant that we need to be able to explain why kids are still depressed or still anxious or suicidal or traumatized even after getting the meds, because that's surely going to happen. And we don't take into account co-occurring events. Like these kids who are going through these outcome studies were living through COVID when all teenagers' mental health plummeted, for example. And we don't, without a control group, we really can't show, and we also can't show the prevention aspect of it without a control group. So without the medication, anxiety, depression, suicidality may have been far worse. So even if it stays stable or anxiety and depression increases a little bit, it might have been far worse had they not gotten the medication, and we don't know that. I think these are assumptions.
Can I just say one thing? So, for years since the start of those seminal Dutch studies, we have been told that these treatments improve outcomes such as depression and anxiety. And indeed, I had some slides. I had a slide from the American Academy of Pediatrics, I think, talking about improvements. Improvements are touted in WPATH Standards of Care 8. The claim is that the evidence supports the claim that these treatments result in improvements. And indeed, you were, I think maybe you're not part of this team anymore, but you were a co-author on CHEN 2023, psychosocial functioning after 2 years of hormones. And in the original protocol, pre-registered protocol for that paper, one of the hypotheses was that treatment with hormones would produce improvements in depression, anxiety, self-harm, suicidality, gender dysphoria.
I had trouble with that because I was one of the authors of the grant, and I told my colleagues at that time that I think that was overstating it because we need to control for prior adversities and ongoing adversities, and that isn't reported. And I have actually withdrawn from this group, but this studies do show some level of decrease in those factors, but we don't understand it. I mean, for instance, we don't even understand who gets access to these interventions and whether it's and this is more along what you're saying than what I'm saying. Access to the interventions might decrease depression because families are supporting the kids. It might be a proxy for family support, for example. I'm not arguing with you that we understand the research or that it couldn't be better. I'm arguing with you that we need to continue doing research and better research, and that
I don't think you have an argument about doing more research.
What?
So I don't think you have an argument about doing more research.
And I don't think we have an argument about the limitations. I've always, just because WPATH is, and I do support WPATH, but just because some people are saying those should be the outcomes doesn't mean I think those should be the most important outcomes. I don't. And I know from working with kids that I've said to every single kid, this is not going to solve all your psychological problems. That's not what it's meant to do. Everybody I know says that to kids when they're getting interventions, and that's really important from a clinical standpoint.
Okay, so I have a few questions, and I'm going to just pick up on the evidence-based. And this discussion reminds me of a discussion we had last year on, is social media addictive? Where we had the head of our addiction clinic who presented clinical data, about her patients, and then we had a social scientist who gave us population level data, and they came to totally different conclusions. And so I'm just curious here, how much of this is on the level of, like, if you're a clinician and you're seeing somebody, so Amy was describing somebody who's suffering, and there's an intervention that, you have a doctor. I mean, just think about your own doctor. You want your own doctor to be informed by the general evidence, but you also want their clinical judgment when they see you based on, their experience and having seen things like this. And so I wonder how much of the disagreement is about the different levels of evidence.
Yeah, I don't know, maybe there is no disagreement here, I'm not sure. I mean, the reason why clinical judgment tends to get downgraded is that the clinicians do not have, I mean, unless they do research, they don't have a bird's eye view of the whole field. They just see their own individual patients. I mean, put it this way, if I'm a homeopath, people come to see me. Typically, you'd like visit some homeopath when you're feeling particularly sick, or you have a cold or something like that, or you have a backache or whatever. I have no idea what homeopaths treat. But anyway, so then I give them the homeopathic remedy, and lo and behold, in a few weeks' time, they're cured. They say they feel wonderful. But of course, that's practically worthless. I mean, as it were, from my point of view, it seems, really encouraging, but that's practically worthless as evidence, because, of course, you'd want to know just how they would fare without the treatment, and people tend to seek medical advice when they're at the lowest point. So you do get a predictable regression to the mean, even absent any intervention. People tend.
But don't you need both kinds of evidence?
Can I so I often talk about this because I'm a researcher and a clinician, so I think I have both those perspectives, and they're both important. But when you see somebody clinical, they're not what you see in research. Research is based on the average, and nobody really is the average. And people don't even want to be the average. When you were born or when you have your children, you don't hug them and say, I hope you're average in every way. That's just not how we are. And every kid comes in with a constellation of different characteristics that are not represented in research. And research is a scatter plot. There are outliers, and then there are averages. And when you see somebody, you need to use your clinical judgment. And it's really important. I think there's worry in this field that clinicians are advocates rather than clinicians, and that people have a knee-jerk reaction that everybody should get medical care. I think that would be problematic if that were true, and I've been an outspoken advocate, if you look me up, for careful interventions with kids, for spending the time to make sure families and kids and providers are able to come together and make good decisions and individualized care. But I also have had patients who I think would have been devastated had they not have access to puberty blockers. And I can talk about case after case, but there are kids who, from the time they were 3, are saying, I am a boy and I've been living as a boy, and even kids in school don't know they were. I've had kids say, I don't remember, but my mom said I was a girl. And going through puberty then as a girl and having to live in a way that's just not at all, consistent with who a kid is, it's hard. It's like if somebody told me when I was a kid, I have to be a boy, it would have been really hard to imagine and having to live as a boy for me, or I'm guessing you as a girl, Alex.
I think I would have made a pretty decent girl.
Do you want to say something more about this? And then I have another question, and then we'll open it. And
just on the, there are undoubtedly cases where gender dysphoric children go through puberty, and as a result, that's just more suffering and hardship. I don't deny that. It is very important to emphasize that the choice is not between transitioning when you're a young adolescent and not transitioning at all. You can always transition later. And so I mean, just take the trans man FG, for instance. So one alternate life course for FG would have been the butch lesbian route, but another one would have been to transition in his 20s or 30s. There are many examples of successful transitions of that sort. And one thing we haven't, I mentioned the destruction of fertility as a consequence of the blockers hormones pathway, certainly totally destroyed if you go all the way to surgery. But we haven't yet mentioned the other bad side effects of early medicalization, the most important of which is compromising sexual function. I don't know if maybe some of you who've seen I Am Jazz might remember that episode when Jazz is wondering if an orgasm is like a sneeze. Marcy Bowers, the former president of WPATH, and who's performed about 2,000 vaginoplasties, has said that she's never seen a male blocked at Tanner stage 2 who's capable of having an orgasm. Now, that might be an exaggeration, but it's certainly not physiologically implausible.
Thank you. I'd like to mention that the research shows both sides. Some research shows that people after surgery and after transitioning have better sexual function than they did before, and that they're more comfortable. But I also think it's undoubtedly a really complicated area with significant ramifications. And we didn't mention fertility, but that's another really important area that I've done a lot of research on. There can be some compromised fertility. Kids are very young when they're making these decisions. Those are really important things to process with kids and their families. It's not clear that there's always compromised fertility, but I think that's a really important question.
Okay, so this raises something else I wanted to ask about, which is about youth.
Let me just
okay.
finish what I was saying. Sorry, I know you want to answer your question. Now I forgot what I was going to say, though. But
fertility, you were talking about.
No, I know I was talking about fertility, but there was something
young
you said.
people.
It's all about young people. I know what I wanted to say. That's really important, and I suggested a reading called "Serving Transgender Youth," and we told it is not benign to transition as an adult versus transitioning as a kid. Not transitioning for somebody who's transgender is an intervention. Your body develops in ways that it wouldn't otherwise. And then many adults who didn't, or older adolescents, really adults, who didn't have the opportunity to prevent a puberty they didn't want to engage with, have to go through many surgeries that they wouldn't have to go through as adults, because of their secondary sex characteristics that have developed that wouldn't have developed, including, chest reduction surgeries, Adam's apple, shaving. There's tons of that, and so it's not just a matter of I can do it later. There's irreversible consequences of not having your puberty blocked that then are expensive and entail surgeries that have side effects, etc. So there's pluses and minuses either way.
The trans man FG, if I could just quickly say that the trans man FG's puberty was blocked at 13, did have to have a mastectomy.
Yeah, so there's irreversible on either side. So I just want to, there's irreversible if effects if you delay and it becomes harder and you want to make a transition as an adult. There's also irreversible if you do it as a child, trying to predict things that actually you don't really know. So there's costs on both sides, and it does seem like there can be costs of over-inclusion and under-inclusion, and so, this is where you kind of hope clinical judgment plus population level evidence could be helpful.
I say that all the time. You want to reduce type A,
Type 1
every
and
kind
type
of
2
error.
errors.
You want to get things right. And it's very parallel to when I used to work in sexual abuse, where some people said every kid who says they're sexually abused is sexually abused. And other people say kids make up sexual abuse all the time, or they're coached to say the wrong thing or to believe the wrong thing. And the truth is the consequences of making a mistake are really horrible at every level. If a kid is being sexually abused and you don't believe them, then they're subject to further sexual abuse and harms. But if somebody is falsely accused of sexual abuse and their entire life can be ruined, plus what are the ramifications for a child if they're made to believe they were sexually abused and they weren't? You want to get it right, in other words, because a mistake in either way has significant consequences. I think that it's just like that here, and we do need more research to get it right. But we also, and what Deborah said I think is true, we also need to have people with good clinical judgment working with kids and families who can contemplate what's best for this individual with them collaboratively and be careful.
Paul's got a question, and then we'll put the poll up, and then we'll open it up to the
Right.
audience.
Well, why don't we put up the polling question? I just want an observation. It's not a question. I want to connect the discussion today to the one we had last week about COVID policy. It's just noteworthy how many important policy decisions turn on evidence. And when evidence is unreliable, as we saw last week with COVID policy, as we see today, that lends itself to ideological division. Maybe in our current policy, in our current culture, everything would be seen as red and blue, but in the absence of evidence, it makes things even redder or bluer. And now let's get the answer to the poll. Essentially no change.
That's okay. Or a lot of change, but it all netted out equal.
It's hard to tell. I think
So we should take attendance and then
People should be lining
and
up
line
to
up.
ask
We
questions.
don't have a whole lot of time, but we can go a little bit over.
more than me.
Okay, go ahead.
Hi. Thank you so much, both of you, for being here. My question's primarily for Dr. Tishelman. It sounds
Can you
like
speak a little louder? I'm a little hard of hearing.
Yeah. If I understood you correctly, I think you said that the complaint from people, like the people who have transitioned and then later detransitioned, is that there wasn't enough like assessment or screening beforehand. And I was wondering if through your like practice in clinical work with patients, you've like come to some sort of model or have some proposed method or strategy for better screening and making the distinction between someone or a child who is transgender or like, I guess, a child who thinks they are and later changes their mind. Thanks.
So she's asking, sometimes for the people who've transitioned, you were saying sometimes there wasn't really good screening or good assessment. And are you in your own practice, and then do you have, guidelines for how to do better screening?
Yeah, honestly, this is another area that hasn't been studied a lot, and I think in the HHS report, Alex and others mentioned that there's an assumption that assessment makes a difference, but it has, and I believe it does, but it hasn't been empirically examined enough, and neither have different approaches to assessment. But from my clinical experience, in an assessment, a lot of issues can arise sometime that can be delved into a little bit more with families. We write about our assessment recommendations in the Serving Transgender Youth article that I was the lead author on, that we published maybe in 2015. However, I think that assessment practices should be individualized depending on the family and the kid. But I think I would say that a really strong assessment takes quite a bit of time, often for kids who are newly coming in to see somebody. Every kid who comes in for medical care doesn't necessarily need an assessment if they've been in therapy with somebody good, like for several years, for example, then it would be redundant. And so I'm probably being a little bit vague, but an assessment usually means gathering information, and a good psychological assessment, because I'm kind of an expert in the area of assessment, usually involves multiple informants and multiple ways of collecting information. That means for kids who are coming in with permission, we would often try to get information maybe from their school or guidance counselor, from both parents. Often families have parents who don't live together, who may even be estranged. We get information on the history of their gender experience, their medical history, their exposure to adversities, the strengths in themselves and in their families, etc., and put it all together and get that information also through some standardized measures, as well as through interviews, and also try to get their understanding of what they think will be the ramifications of going on medical care, what their choices are, whether they've thought through the short and long-term consequences, whether, I think this is something probably Deborah wants to ask about, but whether they can give informed consent and whether they have the ability to think through all of the different factors that may influence their concerns. There's been a lot of concern that has been generated more recently because of the exponential numbers of youth coming in requesting medical intervention and the changing demographics of those youth, where it used to be equally biological sex, boys and girls requesting care. Now it's more like 65% natal girls requesting care, and instead of having a long history of gender dysphoria dating back to childhood, it sometimes emerges in adolescence, and we don't know a lot about why these things are changing. And so I think that means that maybe we need some extra caution.
Okay, I see we have three
Sorry.
people lined up, so yes, go ahead.
Hi, good afternoon. My question about gender-affirming care kind of centers around the idea of differences in sexual designation at birth. So I think you previously talked about intersex, and just how that kind of fits in your framework of gender-affirming care, as well as maybe how it relates to the statistics, Alex, that you showed at the beginning of class. I believe that the current guidelines are more to delay surgical intervention at birth. And so if that is maybe a contributing factor to why we maybe see the higher rates of that gender dysphoria now. Just some curiosities.
I would love to answer that.
Amy, this is
an area
this
of
is
a real
your specialty.
disagreement
But
between Alex and I. It's how we met, actually, originally. But I gave a whole plenary address, or a keynote address, about this a year ago at WPATH conference in Portugal, and I had some slides about this that I had to cut because I had too many slides and I wasn't supposed to talk for so long. But Alex, as he mentioned, and his wife published an article in the New York Times saying that gender isn't assigned, it's a biological fact. But working in the area of kids with variations in sex characteristics, which is also called differences or disorders of sex development or intersex variations, I've seen a lot of kids for whom sex is not very clear at birth, and in fact, it's hard to know what to put on a birth certificate. It becomes important now because I'm practical as opposed to a philosopher, and I don't know what we should put on birth certificates for kids when the gender characteristics don't match what you would expect for a typical boy and girl. And the numbers of people who have intersex variations are the estimates of how many people that have intersex variations are remarkably diverse. So I had slides showing that University of California, Irvine, on their website for the intersex or DSD clinic says that 1 in 100 people have an intersex variation. At Lurie Children's Hospital, the website says 1 in 4,500 have an intersex variation. And other people say it's 1.7% of people who have an intersex variation. And that's because what's considered an intersex variation is not consistent across people. And that's one of many areas of controversy. But I know from a practical point of view that it's not always clear. And the fact that there are people, and in some countries there is a third sex, people who don't really match male or female, or if you base sex, biological sex, on understanding a person's gametes, people who are both male and female, makes it hard to understand biological sex. And you can have a whole separate conversation about that. If you're really interested in this topic, the Journal of Sex Archives has a special issue from November 2025 on is sex binary or is sex not binary. Alex has an article in that journal issue, but it's an ongoing debate. But it does suggest that gender isn't just male or female. People aren't just male or female.
Yeah, awesome question. Let me make 4 points. So the first point is, the Archives of Sexual Behavior series, the question that a whole bunch of people, like 30 or more, responded to with short articles was how many sexes are there, how many genders are there? All of those are open access, and they're well worth reading, especially mine. That was the first point. The second point is that the issue of disorders of sexual development and gender-affirming care, whether young people should be transitioned and so on, are essentially orthogonal to each other. They don't really have anything in common. The patient population that we're talking about when we're discussing gender-affirming care, these people do not have disorders of sex development. They're physiologically perfectly normal. Then my third point is that, okay, maybe I'll just stick to 3 points. I've already forgotten the fourth point. The third point is that just FYI, this 1.7% intersex is as common as red hair trope, which is very common. That originated in a 2000 paper by Blackless et al., one of whose authors was the Brown biologist and gender studies theorist Anne Fausto Sterling. That paper was riddled with errors, and that figure is just utterly bogus, and I go into that in exhaustive detail in my book. So
I just want to mention, you said that people, first of all, in DSM, the Diagnostic Manual for Psychiatrists and Psychologists, when somebody is diagnosed with gender dysphoria, they are supposed to specify whether it occurs or not with an intersex variation. So it's not completely orthogonal. And many people have intersex variations and don't know they have later diagnoses if they're diagnosed at all. Third, we don't know whether people who are transgender have differences, that biological differences. For instance, your and my colleague James Cantor had wrote to the Canadian government that people who are transgender have different brains than people who are not transgender. And certainly we don't have enough research to know whether there is sometimes a physiological difference in development, even hormonal exposure of people who are transgender or not. We can't. I don't think anybody can.
I didn't think Cantor said that.
He did. I actually sent it to him. We're on a listserv.
Oh, okay. All right. I thought Cantor's view. Okay.
I thought that too until I looked at
massive confound.
But we have questions though. But anyway, I disagree with you that they're orthogonal.
Amy, you're coming to MIT next month to talk with James, so that's great.
All right. Yes, my next question is for both of the speakers. So the proportion of U.S. adults identifying as transgender has increased significantly in recent years. What does this data suggest to each of you, and what factors do you believe are contributing to this rise, particularly in the light of the fact that both of you agreed about this increase?
Amy, please.
Okay, I was interviewed in the Boston Globe with sort of addressing that question. I think people have different hypotheses, if you're saying about why there's such a growth in transgender youth. All of the explanations that people have come up with are at the level of hypotheses, and we need more research. So there's some data that people criticize that it's as limited as the data we have on transgender youth to suggest that there may be sort of a social effect where kids are imitating one another. Some people say that maybe there's more trans people than we knew, but in an atmosphere where it was so hard to come out as transgender people and there wasn't any care to access, people kept it private, meaning when you build the services, people will come for the services. Some people think that maybe kids who have other psychological issues are trying to cope and deal with their issues by becoming a different person. I can verify that when I was working in the area of sexual abuse and didn't know anything much about transgender youth. I had girls who were sexually abused and would say, I want to be a boy, I don't want to be a girl anymore. All of these things could be true at the same time, as a matter of fact. There could be some kids who are influenced by other kids. There could be more transgender people than we realize. There could be some people who are mistaking other psychological challenges with being transgender or trying to deal with their psychological issues by claiming it trans identity. I don't know. But that's why we need individualized care and with kids to make sure that they are, understanding what their issues are. For some of the kids who have sued and said, I shouldn't have been treated, like there's a lawsuit that was brought by a former patient at Children's LA where a person who is treated and with medical care at an early age and had a mastectomy maybe at 14 is claiming nobody did enough of an assessment, and in fact she had been sexually abused and was traumatized and nobody realized that. And so people are saying, I should have had more of an assessment before I proceeded on this road, and I didn't. And I think that former patients claiming that is important to understand and to recognize when we do this work.
Yeah, that is a great question. I mean, I think one thing it brings out is that, there's a huge social component to all this, which is by itself shouldn't be controversial. I mean, I've heard Paul Vasey, who's a feminine gay man who's one of the world's experts on the Fa'afafine, this third gender in Samoa, say that if he'd been brought up in Samoa, he would have been a Fa'afafine. So if Paul had been brought up in Samoa, he'd been a Fa'afafine. In fact, he wasn't. I guess he was brought up in Canada, so he's just some regular westernized gay man. It would be like stupid to think that, maybe there are all these closeted Fa'afafine among us or something. That's a distinctly culture-bound phenomenon. And Amy effectively mentioned this new clinical presentation of adolescent females with no prior history of gender nonconformity or gender dysphoria coming to gender clinics, rapid onset gender dysphoria. That was the subject of a very controversial paper by the researcher Lisa Littman in 2018, and she got an awful lot of blowback for it. But the fact is that this is a new clinical phenomenon, and it's even alluded to in WPATH Standards of Care 8. And the idea that this has nothing whatsoever to do with complicated social forces and social media and whatnot, it seems ridiculous to me.
Okay, last question, and we're running out of time, so I'll ask the speaker to be somewhat brief and the answers to be somewhat brief.
Yeah.
Okay, I'll do my best. First of all, thank you both for coming to speak with us. My question is primarily for Professor Byrne. First, I just want to confirm that you're familiar with the famous 2000 Hasslinger paper on race and gender.
I teach it.
Yeah, that makes sense, because I know she's a coworker of yours
Yes.
and that you're
Yes.
familiar in those areas of philosophy. So for those that don't know, it's a pretty seminal paper that discusses ways of viewing race and gender as operating as social classes, which have a lot to do with the way you're perceived by your society and thus treated and awarded certain privileges and or subjugation. So my question is about passability in adult trans people, which neither of you have really touched on, and the way that early intervention can actually lead to better health and life outcomes given the fact that people are better able to pass, which has implications for like medical care, the amount of violence you're facing in your life, and just other, social lubricants, like how nice people are to you and how often you're being verbally abused. So I was curious how that factors into both of your views, and also why that isn't a relevant part of your considerations when it comes to the potential merit of these interventions.
Yeah, that is an excellent question, and that's certainly a consideration. It was a consideration that weighed heavily with the Dutch, in fact. They placed a great deal of emphasis on passing. They thought it was very important. They were much more concerned with appearance than they were with the risks of sexual dysfunction, which they hardly mentioned at all. They certainly didn't seem to be concerned with the fact that most of their patients were same-sex attracted. That was also not a consideration. But yeah, sure, that is one argument for early transitioning, that you'll pass. Of course, especially these days, with the rise of medicalized non-binary identities, like passing is not really the thing.
But it can be when it relates to health outcomes specifically.
It could be, yeah, it could be. And I think the Dutch made, or at least the Dutch sort of conjectured. I really don't know whether this is true, but the Dutch conjectured early on that the reason why late transitioning patients weren't doing so well, because they really weren't, was because they didn't pass. And incidentally, the difference between transgender people and non-transgender people, as far as health outcomes go, that is just a constant, as far as I can make out across. It doesn't matter what progressive society you pick, whether it's Denmark or Sweden or whatever. The fact is that morbidity, suicide, general health is much poorer, significantly poorer among the transition population than not. But
And I think that poorer health outcomes could be related to continual exposure to adversity. This is just general psychological knowledge, is that early exposure to adversities predicts poorer medical and psychological outcomes, separate from anything else. And there's a lot of data on that if you're interested. The CDC has a whole webpage, or it used to anyway, on adverse childhood experiences and how that relates to overall outcomes. And there have been some suggestions that whenever a kid comes to a hospital or medical facility, they should be screened for exposure to childhood adversities because of the long-term effects. And there's been reliable over many studies showing that gender diverse kids and transgender individuals are exposed to more adversities. So those negative outcomes aren't surprising unless kids are treated separately. And as I said, I don't think hormones can manage the cumulative effects of trauma, et cetera, can cure that. So I think that's important.
Okay, please join me in thanking our speakers. Thank you. And next week is fetal personhood.